Good morning, everybody. Welcome to our grand rounds. We have special grand rounds today, but first, a few announcements. The first announcement, great timing. We'll have Dr. Hagen stand up and wave to everybody for her first grand rounds. So I think the residents have met Mia, who was Mia Smuckney when she came here for her interviews, and she's our latest faculty addition. She's a sports surgeon who's joined Albert and Chris and Roger. And she is going to help us build a hip arthroscopy program amongst other tasks. So welcome. A couple of kudos, one for Jimmy Zhu from Susan Stern, who's chair in the Department of Emergency Medicine. And there was another one for Cody Tipton from the staff at Children's Hospital, who commented on his great care of patients on the inpatient floor. It's a busy week this week, and I want to thank Dr. Warm in particular for another great arthroscopy boot camp. Also, Drs. G and Hagen and Kwan for helping out with that. I got to see that for the first time yesterday live, and it's an impressive event. And then also we had the North American Traveling Fellows, and thank you to Teresa Jones for helping to organize that, and then Lisa Tatesman and Carla Bellababa, who helped me take care of the fellows for several days. And I think they had a nice time and a good educational experience. And then this is also the week of great tradition that we've had for many years now, and that's the Garrick Lecture that was started by Colleen Johnson and Jim Garrick, and you'll hear a little bit more about the history of that if you make it to the Garrick Lecture tomorrow night at the Seattle Tennis Club. And for the Garrick Lecture this year, we have Riley Williams III, who's visiting us from HSS, and we're all excited to have him here, but there's probably nobody more excited than Albert. So with that, I'm going to have Albert introduce Dr. Williams.
Thanks, Howard. So yeah, definitely a very big pleasure and a privilege to introduce Dr. Williams to you guys. Dr. Williams has been in the business for about 20 years. He's going to talk to us about his experience with articular cartilage repair and restoration, which is his kind of area of expertise. He's internationally recognized authority on that topic. So we're really excited to hear about that. But just to give you a little background about Dr. Williams, I trained with him about 5 years ago. I know that I've been out 5 years because I just got that 5-year pin from the UW. Because it's so small, like you can't even see what it says. I don't know why they get it. The pin is silly, but okay. This is going to be on the thing, so I'm going to be a little cautious. But Dr. Williams was a mentor for me at special surgery, just an overall good guy, confidant. I had the privilege of taking care of some of the pro teams with him. At that time, the New Jersey Nets, before they became the Brooklyn Nets, and so that was a real formative experience for me in terms of team coverage. In my residency, I did not know much about team coverage, and that's something I learned a lot from Dr. Williams, so I really had to thank him for that. And then, just to give you a little background, Dr. Williams is from LA originally. Grew up in LA, and then went to Yale for undergraduate. I think he was a soccer star there for a number of years, and then I guess that probably sparked his interest in sports medicine somewhat. And then he was back on this coast, where he was a medical student at Stanford. And then did his residency and his fellowship in sports medicine at the world-renowned HSS, Hospital for Special Surgery in New York City. And I think when a fellowship keeps you, that speaks volumes. And he stayed on there and was kind of their cartilage guy, and has done some really great things. Is world recognized for his work in cartilage, and kind of the go-to guy for that in that practice. I hope some of you will be at Garrick. I have a couple more things that I think a little bit more personal and perhaps a little bit more humorous, but I felt this was kind of a more formal setting, so we'll keep it tight for this. But We're really happy he's here to give us his talk and spend a couple of days with us. I'm really excited. I haven't seen him for a number of years now, and he's really just a great guy and a good, a fabulous surgeon, so I'm really excited to hear his talk today.
So, thanks for having me. I just want to thank you guys for having me for the Garrick in particular. I take these trips seriously. I prefer these types of venues because I kind of get to come and speak and give the talk and then interact, because the quick in and outs they tend to be less personal. And I think for me, one takeaway I've already thought, like, when are we going to do our own arthroscopic boot camp? Because I'm sure it would take my blood pressure down a lot in the operating room in terms of residency education. So I look forward to chatting with you all and kind of hanging around the practice for the next couple of days. And what I will say is Al is he takes a special place in my heart. He's one of my favorite fellows. Clearly my staff's all-time favorite fellow. They still talk about him to this day. So as you know, when the staff and your support group loves someone, then they must be truly lovable. So anyway, so one preemptor in terms of my talk today. It's a narrative talk. It's not a summary of all cartilage repair in the United States with slides and slides and slides of results. It's sort of like my thoughts about this, having been handed a practice which is essentially osteotomies, microfracture, and ACIs, and a bunch of unhappy patients who had failed some other procedure, and that was back in 1997. So here are my disclosures. So we'll start off with this little video. So I'm sitting at a game, and you see the guy from the Nets takes a fall down there. He'd literally been in the game for about 30 seconds, and you see foot fixed, valgus forced, guy sets a pick on him. Nothing harsh or illegal about that play, but obviously resulted in some issues. So he's 21. The Nets have been a bit of a bottom dweller team of late, so they're devoid of draft picks, so they're constantly trying to find players who are sort of what they call bargain analytics players who've not had the opportunity to demonstrate potential. And Sergey, I'll use his name because he has given me the right to talk about it, suffered this injury, so they were very upset about it. So, big effusion. I couldn't really examine the knee much. He's unwilling to range, so as we like to do, we did an MRI the next day. So this is the MRI. So you can see up here at the top this rather large articular cartilage lesion of the patella, and right up in this area here with fragmented articular cartilage pieces here, and this on the sagittal view. So here's what the operative view is, and I won't talk about the surgery, but the confluence of injuries included a complete MPFL tear, a grade 3 MCL tear, this large 25 millimeter plus diameter, full thickness grade 4 lesion in this young player, as well as involving 70% of the surface area. So the interesting anecdote here is, everyone was asking me, not if this player would ever be able to play again, but when was he going to be back? This happened I think this happened in February. Camp for the NBA starts in September. So that gave me roughly 6 to 7 months to try to scoop this guy up, fix him, and have him back to play. And that was the legitimate expectation at that time. There was no irony or wonderment about if this was a terrible injury. It was really like, okay, so you're the cartilage guy, and this is going to be fine, right? Because we need him. Right? As though that somehow had an issue on the, what I would be able to do. So this really is sort of the framework of the talk, is like, is this type of reconstruction and return to play a reasonable expectation? And I think now, in the current day, there are some evidence-based drivers that we can use to sort of help us make these decisions. So as we all know, as a course of review, articular cartilage has a very poor capacity for repair. It is made embryonically with a retreating vascular supply once you reach skeletal maturity. So the chondrocytes, remember, are isolated and non-proliferative. So when there's an injury to articular cartilage, there is no natural way for nutrients, chemokines, other types of healing mediators to make it to the area in question because of the poor vascularity there. So in the healthy osteochondral unit, everybody knows these pictures, these chondrons with chondrocytes sitting isolated within the matrix and the subchondral bone. And then you have an injury, you get the development of some surface fibrillations, increased water content in that phase, as well as probably most importantly, the release of pro-inflammatory mediators, nitric oxide, and other RNA-based sort of signalers that start the degradative process. And then with time, you get loss of ground substance, changes in subchondral bone, and ultimately gross erosion of the cartilage. So that sequence of events, once it starts, happens, for example, in ACL reconstruction when you have the femoral bone bruise on the femur. We still don't understand why some of those lesions progress to full thickness lesions and some don't, but that basically, if you really think about articular cartilage lesions, there are shear events like the ACL or MPFL, dislocations of the patella, OCD lesions, and then what I'll call just early degeneratives, post-meniscectomy, varus malalignment, valgus malalignment knee. So cartilage lesions just don't happen randomly. They can happen in very succinct type of situations, largely due to some sort of abnormal biomechanics. So what's the first challenge in terms of getting these players back after a cartilage injury? You want to restore, obviously, the functional anatomy. Because of the low intrinsic repair potential, we as surgeons have to create conditions that support the development of new articular cartilage or put new articular cartilage in a whole phase back into the joint. There are no validated algorithms to guide clinical care. This has been the case forever. It's very difficult to do randomized clinical trials with these types of methodologies, and the ones that are out there, largely because they're so expensive, are industry-based. So the second thing you have to do is to restore joint homeostasis. Remember, normal joints are a balance between a degradative process that leads to the normal turnover of articular cartilage and the formation of ground substance by the chondrocytes. And when you violate the lamina splendens in the cartilage, you inherently, at that point, tip the balance toward catabolism. So what I really found, and you hear me talk about a lot in this talk, is I feel like I've gotten really good at restoring anatomy. I'm abysmally woeful at controlling the homeostatic environment. And as you'll see with some of the long-term follow-up, short-term gains may result in some sort of long-term degradative issues that may ill-affect patient health over the long term. And so I think this is something, at least for me, in terms of my second half of my career, this is really where my focus is going to be, really controlling synovitis, this chronic inflammatory process that starts because of these early degeneratives. They finally get fixed because of the typically long duration of symptoms that they have. And then even though I can go in and fix the cartilage per se, the knee envelope is still abnormal, and I just don't really have a really good way of correcting that, at least on a timeline that makes sense. Challenge 3, which people don't really think about, restoration of fitness. Again, he was not like the guy you want to hang your hat on in terms of like being serious about his craft. Very good basketball player, but not a fit player, right? So now he finally gets into a game, and who knows if some of that contributed to the injury. Maybe it did, maybe it didn't. Point is, like, I really felt behind the 8 ball with that guy in terms of what the expectation was going to be. So aerobic conditioning, strength loss, proprioceptive loss. Remember, unlike an ACL, and I do a lot of ACLs as well, that's my primary practice, ACL and cartilage surgery. ACL is a succinct episode. This person was fit, soccer player was fit, they got tackled, they tear their ACL, they come in 2.5 weeks, 3 weeks later, we do ACL reconstruction, and they're back on the rehab path. Most of these early degeneratives have had symptoms for a long time, 6 months, 12 months, 2 years. A lot of them have had prior surgery, which we'll see in the literature has ill effects ultimately on their outcome. So it's really a different condition. So when I get these high-level players coming into me from other teams or from outside, one of the first things I do is a movement assessment with a battery of about 10 standardized tests, hop tests, 8-inch step down, things of that nature. So I sort of see who I'm dealing with and what are the things I'm going to have to address in the perioperative period after I've taken care of the defect. So these are the sequences, right? Cartilage defect, you got to determine which surgical repair reconstruction method you're going to use. That helps you to achieve defect fill. Then you have to worry about rehabilitation and the correction of joint homeostasis, as I just discussed. That'll lead to decreased pain, increased function. Then you can get more vigorous in terms of actually what I call transitioning from physical therapy to fitness training with a strength coach of sorts, and then ultimately return to sports. That's a long list of requirements. And so I only put that up there, especially for the residents who are listening, to understand that you guys are in there with me. We're doing these Osteo No Allografts, and it's really cool and fun, but that's the easy part. This is the hard part, everything from defect fill on down, where there's a lot of variability in the system that has to do with you, the practitioners on the ground who are helping you, the actual athlete who's involved. So these are the things that I'm thinking about as I'm interviewing patients. So I would posit that return to play as a realistic goal following articular cartilage surgery is a new phenomenon. When I started practice in 1997, again, I mentioned this earlier, there was ACI, which was new, microfracture, which was like kind of the hot thing because it was easy and you could do it, and everything I read or answered at a test talked about doing osteotomies around the knee. So I was like, all right, I got to be able to do TTOs and DFOs and high tibial osteotomies and such. We were never talking about sports. We were just talking about being able to be functional, walking around Manhattan, maybe some light exercise, cycling, but certainly not any kind of pro athleticism. And this is around the time that you were hearing about all these pro athletes getting microfractures and ultimately not doing all that well with that. So in a historical context, and again, this is important for the residents, 1980s, arthroscopy starts. This starts an awareness of cartilage lesions because everyone's getting a scope as opposed to an arthrotomy, which increases the volume of cases. There's a little historical precedent as to how best to treat these lesions, and there is no imaging that's predictably successfully seeing articular cartilage lesions in the knee or shoulder. So what will happen is this clinical scenario where a patient's thought to have meniscus pathology. They usually have x-rays. Maybe they have an early form MRI, which typically doesn't show cartilage, so you see a meniscus tear. Surgeon goes in to take care of the meniscus. Lo and behold, big medial femoral condyle articular cartilage lesion. And now there's all this angst, and I remember this angst acutely because it happened. I'm telling you, it happened all the time. What do I do? Do I treat this lesion? Do I leave the lesion alone? You know, are we really here because of a meniscus? Is the cartilage problem the primary problem? There's been no preoperative discussion of this issue. So, and then now you're faced with a choice. You know, you told the patient it was going to be a quick recovery, 4 to 6 weeks after a typical scope. Now you're talking about a microfracture in all likelihood, 6 weeks on crutches, CPM 8 hours a day, and we shortened that to 6 hours a day at HSS. Dick Stedman is going around the country lecturing about microfracture and saying HSS's results are not as good because they only do 6 hours a day of CPM, not 8 hours. I mean, it was very, very, there was a lot of controversy around that time. And this, I never felt comfortable with this clinical scenario. I thought this was exactly what we should not be doing, meaning if I didn't have some sense of what I was going to be doing and we haven't talked about it and you understood it, we were already behind the 8 ball with regards to outcome. So this was the state of the art in 1995, 96, 97. So we had to change that somehow. There really weren't any early cartilage repair options. You didn't do a knee arthrotomy to do cartilage repair unless you were doing some sort of transplant. So there was chondroplasty, there was drilling, there was abrasion arthroplasty. Lanny Johnson, who was a big proponent of abrasion arthroplasty, basically was quoted in a core article saying that this method is for patients seeking an alternative to total knee replacement, and that ultimately, through his follow-up work, he determined that the biomechanical properties of this reparate was inferior to articular cartilage. So you wouldn't do an abrasion arthroplasty for an athlete. It was not even part of the onus back then. So abrasion and drilling allowed doctors to feel like they were doing something. We all have that sort of piece of us that says, hey, there's an issue here, we want to try to fix it. And as a result, you saw, again, in conjunction with the arthroscopic methodologies, lots of drilling, lots of abrasion, and lots of poor and unpredictable results. So 1994 happened, and congratulations to OJ this past week. This article was published, and I cannot tell you the cataclysmic or just disruptive nature of this article. First of all, talked about being able to treat deep cartilage defects with autologous chondrocytes, but it was published in the New England Journal of Medicine, which I don't think I've seen another major article orthopedically published in the New England Journal of Medicine. This basically alerted the world, the country, that doctors could now take your cells, grow them, and put them back in your knee, and that this was going to obviate total knee replacement and be the new standard of care in terms of salvaging knees that heretofore were being pushed down this arthroplasty pathway. So this was all the rage when I started. I mean, you had guys who were arthroplasty surgeons doing it. You had guys who were really in a race. They wanted to be part of the early study group. I mean, it was really like everybody wanted this designation of being an ACI surgeon because it was such a hot topic, and there was a lot of extra medical consumer interest and people coming in and asking about it. So he had a lot of people doing Carticel, and that's when I started my practice. So there were good clinical results in the literature, but certainly I can only tell you from my practice, because when I started, I did a lot of them. It did not translate. Very technically difficult, very expensive. Approvals were difficult, and I had a personal reoperation rate in my first 200 of about 50%. So a surgery to harvest, a surgery to put in this patch, and then a miserable patient for 6 or 7 months, and then you go in and it's this big ridiculous hypertrophy of periosteum. So now you're debriding that. I mean, it was a mess. And so I said, this is not going to work for me. So basically, what happened with ACI was the case volumes dropped. The success reported in the literature did not translate to surgeons, at least here in the U.S., so that left us with few options. And that basically allowed microfracture, despite the fact that microfracture never was subjected to randomized clinical trialing or formal adoption by surgeons. It was sort of like the last method standing. And again, Dr. Stedman, listen, he's a world-renowned sports surgeon, probably one of the original guys out there who had some standing and reputation. Was out really talking about, see, you know, you have to pay for this. It's one stage. It works for me, and it sort of became part of the lexicon. So we were very active, had a busy group of surgeons, primarily doing ACI, and that basically led to us forming a Carla study group. And I felt like, well, Hollis Potter was in the operating rooms. The only radiologist I've ever seen, she came to the operating room and basically had scanned, and she would come in and herself, she would look at the scopes, document from the arthroscopy, and correlate it and kind of fiddle with the signal patterning down in MRI, and was able to start imaging articular cartilage, which was a huge game changer, because now we could have these talks with patients diagnostically, right? So we made our outcomes unit, and the big thing was, you know, we wanted to start collecting PROs prospectively to allow us to look objectively at these methodologies and make some statements about it. So this data has driven my practice. When I quote numbers to patients in the office, it's registry data. It's not my general consensus or what I think works. So it's allowed me to be objective and to always be responsible and look back at what I'm doing with a critical eye. So we talked about this. What are the etiology of the injury? We hit that. Shear injuries, early degeneratives, and OCDs. You have to think about, in terms of what you're going to do, what is the physiology of the repair method? Putting in a whole tissue transplant is different than an ACI. An ACI has to have a biomechanically favorable environment in which to grow. So now you have to start thinking about osteotomies and things. However, if it's whole tissue, maybe you don't. I'm not saying there's any strict literature or guidelines of that, but that's sort of the thought process you should have. Surgical execution, especially with regards to some of the more technical methods, can I do it? Am I doing the patient a favor, or am I experimenting on someone? You know, again, something you have to think about. Joint homeostasis, always, at least in 2017, on my mind. And then what is the rehab fitness restoration plan, and can the patient actually do it? Because it's very hard to do 4 to 5 exercise sessions a week when you work or go to school, right? So here are the options, at least in my mind, in 2017, and things that we're doing. Palliative, I just bring this up because it does have a small place, by and large, for elite athletes in season. Yeah, you got some OCD lesion, it's delaminated like this picture here. You go in and you just debride the area in question to allow them to remove the mechanical irritant, and they can go back, and then we can go back and do some sort of definitive repair at a later time. I really don't advocate this one, but I do take care of a pretty big swatch of what I'll call, 16 to 23-year-old high-level high school and college students. Sometimes we do this, but really my bias is take the season off, because multiple operations and extended symptom duration has a negative effect. Moving on now to marrow stimulation. Again, this is by and large, we're talking about microfracture. The whole idea here is that you're recruiting pluripotential cells from the marrow into a defect in order to get some sort of repair tissue to form. And it remains, despite all our advances, the predominant articular cartilage repair method employed in the United States, even in 2017. Advocated by Stedman, is technically simple and inexpensive. Again, it is the gold standard. And the only surgery, I believe, in orthopedic surgery where you finish the case and you're just hoping that what you just did is going to happen, something's going to happen. Like, You do a total knee, you look at it, you test it, you make sure it's stable, you take it through range of motion, and you give yourself the high sign. This thing, you make holes and hope, which never, again, never sat well with me. So we don't have to go through the method of it. I just don't think people are doing it much now. But here's the issue where I think things sort of fell off the rails. You had to have a shoulder of healthy cartilage to help capture the clot. I don't have the picture here, but I had a picture that I just went around, and when I saw people were doing microfractures, I just took a picture of the lesion they were treating. And there was always this reticence by surgeons of debriding the lesion. You had to make it bigger. So you'd see a little hole, there'd be a little bit of, remnants of calcified cartilage left. They wouldn't take that out. They wouldn't cut the lesion back with a shaver. You have to make the lesion about a third bigger. So you're making maybe something that's 17 millimeters, 26, inherently makes you uncomfortable. But the physiology of the microfracture clot repair is that you have to capture the clot. So you're not doing what you're supposed to do in order to make it work. So you had all these variables that had nothing to do with the patient and everything to do with the surgeon negatively playing into this method. Then they had to be on crutches for 6 to 8 weeks. Then they had to do 8 hours of CPM a day. And by the time they got back to you at 6 or 8 weeks, you literally would shudder looking at your patient list when they're like, okay, what am I going to see when this patient comes in today? Are they going to be furious with me? Are they going to be happy with me? Are they going to be limping? What yarn am I going to spin about how this is going to be better? And how can I kind of get them through it? And that was my office hours. It was pretty miserable. So I just don't think it's realistic in terms of compliance. So we started publishing out of the study group, and these are simple take-home messages. As you would think, fill grade correlates with outcome. Okay, pretty simple, right? And there are some parameters that will predict success with microfracture: age less than 40 years, small lesion size, BMI less than 30, and a symptom duration less than a year. But what I want you to remember in terms of microfracture, it always loses, it always deteriorates no matter how good it is at the beginning. If you look at them longitudinally, it always gets worse. So we pulled out a subgroup of pro and college athletes, and again, take-home message here is that, you had a 44% return to sports at a minimum 2-year follow-up, and if you dig a little deeper, only half of that group achieved what they described as a pre-injury level of function. So deterioration between 2 and 3 years, really a 22% return to effective sports. This is just a loser all the way around. And another prospective PRO-based study, Italian group looked at their national Olympic athletes, and again, very similar results, good results at 2 years, with a deterioration of results over a longitudinal timeline of 15 years. Over half had increased pain and swelling at the 5-year, 15-year follow-up. And again, they basically supported some of the things that we supported, young age as well as a 2-centimeter diameter lesion size as a threshold. So at the end of the day, always unpredictable outcomes, protracted rehabilitation, poor durability, 44/22% return to sport, and just remember, this is the FDA standard to which all new technology must be compared. It always loses. Microfracture has never won a randomized clinical trial. It has lost every single one. But that is the standard to which we're held. So it's tough because I've been part of it. So when you're doing a randomized clinical trial looking at some cell-based therapy that you think has potential, the FDA is telling you, yes, you need 500 patients in this study. It's going to cost $20 million. And you're going to have to convince a third of those patients to have microfracture. Everybody sitting in their office has a little computer. And when you step out of the room after you tell them about the thing, they say, well, Dr. Williams, here, I saw your lecture, and it says microfracture is terrible. So why would I want to do microfracture? And what am I supposed to say? So it's very tough, and it has created an environment now that has made it very difficult to get new technology, at least in the cartilage world. So whole tissue transfer, which is really where my heart and soul is in terms of these types of repairs. Basically very simple, trying to get either autologous or allograft whole tissue transplants into a defect. And these have been around for a while. This was osteochondral autograft was first described as mosaic plasty by Hangotti. Was a really very utilitarian grafts, and he could treat pretty much anything. I do a lot of these, and have really tried to get into the hearts and minds of guys. If just do an autograft on something you think needs a microfracture. It takes a little extra time. Get facile with it. Go to the lab. Learn how to do it because it'll pay dividends. This is the most commonly requested method requested by orthopedic surgeons. I'll probably say I've done 20. They've all had an autograft. So Aaron Critch, who is very effective, he's at Mayo Clinic now, came in and really did a good job at mining our registry. And he did a functional outcome comparison between microfracture and the autologous transfer, again, using the same PROs. And again, take-home message, he had a better Mark's activity rating scale at 2, 3, and 5 years, and it was durable. And he observed that same falling off of outcome measures in the microfracture group. So. So in another trial, again by a group off from Europe, they looked at the same groups, and again, sorry guys, same comparison, large group of patients at 3-year mean, and the same durability issues here. 96% of the AOT group was good to excellent, relatively only half the microfracture group, and again, these same parameters noted here with regards to lesion size. So again, microfracture keeps losing. So I like AOT. It's single stage, hyaline cartilage, and it's durable. It's technically difficult, less so. I always do these things through a small mini open approach. I don't think you should do cartilage surgery through a scope. That's just my bias because you only get a view of about 180 degrees at which you're working at any given time, and congruency and placement of these grafts is not insignificant. So it's just something I would tell you to keep in mind if this is something you think you're going to do. So this is good. Allografts, done a lot of allografts. I do about 150, 160 knee allograft transplants a year. And just as a mean of review, these are viable allografts that are commercially available, and we're looking at some of the viability, but this is just some of the early viability slides of some of the grafts that were coming out. 20 to 28 days is where I try to land. You can see this 40-day allograft doesn't have a whole lot of viable chondrocytes. We do not know how many viable chondrocytes you need, but there are some. We just wanted to verify that, and we'll continue to look at that. So one question we did early on in the lab was basically how long could you keep cells viable in the lab? And you could see over a 60-day period, you had well over half the chondrocytes remain viable. We also did another study in sheep where we took stored allografts and put it into the knee of sheep after 1-day storage, 14-day, and 42 days. So the main take-home message from this busy slide is basically to show that it's better to have some chondrocytes than none. So here's your freeze-thawed group, right? Biomechanical properties here, significant increase in all these groups here, 1, 14, and 42, versus the freeze-thawed. So having viable chondrocytes matters in terms of proteoglycan content, and having viable chondrocytes mattered versus none in equilibrium modulus. So ground substance was up if you had viable chondrocytes. Biomechanical properties was maintained if you had viable chondrocytes. So you need some chondrocytes in the grafts to allow some durability there. These are utilitarian grafts. They work great, and they can be used in revision surgery, uncontained lesions in active patients. That's a condyle to the left, patella in the middle, and a trochlea, a big saddle graft, 30-millimeter graft that I did in someone's trochlea. So I do a lot of that. Busy slide, but basically just to show you that osteochondral allografts, at least prior to the mid-1990s, was the most published style of cartilage repair, right? Because it had been done in the tumor literature a lot. So our first study that we put out on this just basically showed that at a 4-year follow-up, you had significant increases in all the PROs that we typically looked at, but that unlike some of the other methods, BMI, age, storage time did not have any effect on outcomes. So that was really a revelation. So you could put it in anybody in any circumstance and expect some reasonable results. We then looked at, again with Aaron, our high-demand athletes, the same pro and high-demand group, with again a mean age of about 32. Big pre-operative duration of symptoms, and over half had prior procedures. Again, 88 return to sport. So we were effectively using this whole tissue transplantation model. We doubled our effective return to sport with a 79% return to, so that's 88 versus 44, and then 79 versus 22 in the microfracture paper. So I like the allografts. They work well. They're not perfect, but again, this is a relatively short-term outcome. Bill Bugbee, who is another big guy down in San Diego, I'm sure you guys are all familiar with, he looked at his experience with the same group of patients and got pretty close numbers, 75% return to sport and a 79% of what they described as high-level activity or returning to pre-injury morbidity, which is good. So I like the grafts. It is my preferred repair method for these big defects, revision surgery, and patients who have had long symptom duration. So. Cell-based repair, really quickly. This is the ACI, which is still around. It has gone through some iterations over the years, but again, it does have a evidence basis for use. So this is the Cone group out of Italy. They looked at a group of high-demand athletes and again did a randomized clinical trial comparing to microfracture, and basically were able to demonstrate a return to play of microfracture at about 8 months and a similar, a little bit longer, 88% return to play at 12 months. But as they went over the group longitudinally, again, as is typical happens, microfracture deteriorated, the ACI group did not. So there are evidence here. You can get athletics in 80% of patients. I don't like the 2-stage, but if this is what you have available and you're comfortable with it, there is the evidence basis for its use in basketball and soccer players. So I don't like the extended time for non-weight bearing. I think the 2 procedures makes it more difficult on the rehab side to achieve the fitness levels you need. But again, good in terms of athletes. So if you're thinking about something with regards to athletes, AOT, cell-based ACI, and allografts right now are the only ones that show any real utility here. There's going to be more interest in cell plus scaffolds. We have the MACI, which is now available, plus the NeoCart and NovoCart, which should be available in the next 2 years. And these are cell-based repair methods with a scaffold. ACI went from a periosteal patch to a collagen patch, which then went to a cell-seeded patch where you literally just drip the cells onto a porcine membrane and sew that in. We're now to the MACI, which I'll just hop ahead to, which is now available here in the US. So that is a cell-seeded patch, which is processed and shipped to you, and you can put in. And it's been available in Europe for over 15 years, so there is some data on it. This paper basically shows that in a prospective PRO-based study, 5-year follow-up, we had 74% return to sports at a pre-injury level. So if you can't get an allograft and you're comfortable with the ACI procedure, the MACI probably represents a pretty good option for most lesions. You could put in a trochlea, you could put in the patella, you could put on a tibia perhaps, as long as it's constrained. I've done probably 5 or 6 of them since it was approved the early part of the year. And it's a pretty easy little surgery. It is 2 surgeries, but I'll be able to have a little bit more to say about it in terms of MRI follow-up. But again, the evidence does exist there for the use of MACI in your high-demand athletes. I just put up NeoCart because I was part of the NeoCart trial. The nice thing about NeoCart, again, it is a cell-based system, but it is subjected in the lab to hydrostatic pressure, which mimics walking, which makes the cells plump up and make ground substance. So you can almost think about this patch that you're getting to put in as having been primed, ready to make ground substance with the patient's own cells. And again, I've been involved with this trial for about 7, 8 years now, and it has some of the most impressive looking follow-up MRIs that I've ever seen in terms of fill and iso intensity of normal cartilage. So more to hear about that as we move ahead. I bring up the scaffolds. I did a lot of these in the mid-2000s, and it got a bad rap. I only show it to say that this is a patient I did and had 8-year follow-up on, had some of the best articular cartilage follow-up MRIs I've ever seen. And by and large, based on the OBI experience, this method was panned because a lot of guys had these cavitary lesions that showed up in MRI 1 and 2 years. I had so many, I just wasn't seeing the negative patient outcomes that everybody else was seeing, so I persisted. And it's just a method that I think, if we look at the economics of medicine moving forward, we may not always be able to do these surgeries that have 2 procedures and these protracted rehab things. So we probably should pay a little bit more attention to these 1-stage acellular membrane type methodologies. So move on past this. Great. Minced cartilage. Now this is available. And the particulate juvenile articular cartilage, de novo. And again, this is cartilage from young patients. They don't give you an age. From what I understand, it's up to about age 7. Why? Because if you look at the top slide up there, juvenile cartilage has a hypercellular reactive cell population, unlike adult cartilage. And you could take advantage of that phenomena when you mince it. And what was observed in a lab was that some cartilage was harvested, I think, from a tumor patient in the knee. They minced it up, put it in a petri dish, forgot about it, came back a week later, the bottom of the dish was full of cartilage. So from that happenstance finding at WashU, they came up with this product here. Not a lot out there, a couple of small case series, which basically show at a relatively short follow-up. Farr and his group, PROs showed an increase in PROs at 2 years. with the persistence thereof. This is from Iowa Journal of Orthopaedics, very short-term follow-up with a mean increase at 8 months. Tim Wong and Dean Wong at our institution looked at my patients who had 30 lesions, again at a 3.8-year follow-up. Significant increases in IKDC and the KUS ADL score. High BMI had a poor correlation with outcomes. And lesion fill, surprisingly, did not correlate with outcomes. And the T2 MRI analysis, I MRI everything, did compare favorably to articular cartilage native, but was not normal. So improved pain and function for patellofemoral lesions, where all these were, significant lesion fill in MRI, but again, we'll have to see how that does over the long term. So my guy at the beginning got hurt, had all these issues. I didn't want to do a big invasive procedure on his patella. So I went ahead and I did a de novo on the patella because I didn't want to violate anything. It was pretty reactive. I used 2 packets of the stuff and did a primary repair of the MPFL and the MCL repair off the tibia. At 1 year, he did return to play, and at 7 months, he returned to play. And at 1 year, you can see up there at the top, we have a pretty good persistence of lesion fill right in that area there. So that's native cartilage. You can see that hypointense stuff here in the middle. That's an anchor from the MPFL repair. So I really didn't think this guy was going to make it back. He's one of my best ones ever. I had a guy who totally was in shape and ready to go with a teeny tiny little lesion in the trochlea. It's been 3 years. He never got back. So it's really something that you have to just take with a grain of salt because you can't control every episode. I throw these meta-analyses in only because it's a good summary slide to think about when you think about sports. Return to play after osteochondral autograft is 93% at a 5-month interval, which is pretty incredible. So it's hard to argue when you can do it against an autograft transfer. OCA's 88% at about 9 months, ACI 82 at 11 months or a year, microfracture again about half at 9 months. So overall rate in this meta-analysis of 76%. Another meta-analysis came out right around the same time with very similar numbers. Roughly 89, 90% with OATS, 88%. That 88 number with osteochondral allografts is pretty consistent, right? And then ACI and microfracture coming in 3rd and 4th. So in-season management for palliative, microfracture I would encourage you not to do. AOT I think is probably the best lesion if you can facilitate it in the lesion size that you have. Allografts, I do like. What I'm seeing over the long term of allografts is some delamination phenomena, especially in my NBA athletes, which I'll be able to talk about maybe a little bit tomorrow. ACI does work, but it's going to take a long time. And then PJAC, at least in patella lesions, I think there is some anecdotal evidence that does work. But again, the data's still out. So I want you to understand your lesion etiology, understand the physiology of the repair, do what you know how to do surgically to be effective. Try to, as best you can, address homeostasis. That can be PRP, Wharton's jelly. I mean, I'm really pulling out the whole book there. It's really a black box to me right now. Elucidate and address functional deficits with return to strength. And then also set up physical and psychological expectations. And I do use a sports psychologist sometimes for some of these multi-injured guys just to kind of keep them up and going. So the last thing I'll say is successful return to play will often follow when you least expect it. So here is a case. This is a former Rookie of the Year who had 4 scopes for seeing me. So the GM and I were on the phone, and I said, hey, I want to do a surgery on this guy. And he says, well, that's a very controversial surgery. That could end his career. I'm like, his career is effectively over. He's got bipolar patellofemoral arthritis, okay? So anything I do in here is a salvage, and there's no way you can lay whatever expectations outcome on me. The die is cast. So I went ahead and took this case on and did 2 grafts in the trochlea. That's a 30 and a 27.5, I believe, and then a 25 millimeter graft on the patella, all from 1 full distal condyle. So what was I thinking? I think I was pretty crazy. So anyway, he then came to Brooklyn the next year, got back to play at around 12 months. And so it's Tyreek Evans. Tyreek was the Rookie of the Year, I believe, 2010. And just take a look at him. He's got good lateral movement. He can elevate. Shocking. I mean, there's no way I thought this was going to work. So, But this guy, again, you got to think about like the conditions, right? He contract year, highly motivated. Guy makes 11 million a year. He can make 12 million next year. I mean, the point is, you know, there are anatomic considerations, and then there's those extra anatomic considerations which none of us can control. Hopefully, I can come back in another 10 years and talk to you guys about how best to control the joint homeostasis and swelling that are so endemic and common in these patients. But for now, I like where we're at, and I'm happy to say that over 20 years, we've been able to shed a little light on what works in these patients. Thanks for having me.
Any questions from
Questions?
the audience?
Yes.
So Age, obviously.
Hey,
first of all,
excuse
Yeah.
me. Let me
On the-
use the mic so the people off-site can hear.
Thank you very much, Dr. Williams. That was great. Obviously, age impacts biology. So I was curious on how age drives your decision making and what you propose to these patients, and do you have cutoffs, et cetera?
Yeah. So I was just talking to some folks outside. I mean, when you give these talks, you have to sort of have an arc. There's a whole lot. I could give you a 3-hour talk on allografts, because I really, that is really kind of what changed my practice. I did notice, like, I did the first allograft, I think, in New York commercially in 97 or 98. I don't remember what it was. But that subgroup of patients who were sort of the disaster group, they were typically 42, 45, you know, so that was really the group of patients I started with. And I start with that only to say, I noticed that allografts were making my worst set of patients happy quickly, like almost immediately, which was very unusual in my practice flow. So it's taken 20 years for me to demonstrate that you can do osteochondral allografts in 40 to 60-year-old people, and that article will be coming out in American Journal of Sports Medicine, I believe, next month. So I don't really have age cutoffs. That same paper does demonstrate that your KL score going in does have an effect on your survivorship, but if you take the whole group as a whole, I believe it's 80 patients or something like that, it's a 90% survivorship at 13 years. Crazy. So I look more so at joint condition, joint homeostasis, what's the cartilage condition? You know, is it an isolated area? Or does the joint show any signs of sort of that really a gross tip towards a catabolic side? Because you'd just be putting a graft into a hostile environment. But I think my thinking on that has evolved. So for allografts, I don't think I have an age cutoff. I think for the other methodologies, they haven't really focused on it, so I don't have, for example, for ACI, I don't really talk about the effectiveness of ACI in 48-year-olds, right? Because I don't think the Europeans who largely drive that narrative do it in those patients. They try to, and they don't have allografts in Europe. So for people to understand sort of the current status, they don't have allografts in Europe, so they pretty much exclusively do cell-based methodologies, and that's where they make their bones. But when we go to ICRS and we talk, they're all like, oh, I wish I could have allografts. You got to help us get allograft, you know, because it's such a clear-cut winner in terms of effectiveness, durability, and the rehab time. Make sense? All right, good.
So a question from remote is, the bulk of the presentation focused on caring for high-demand athletes. The majority of the residents going into sports will be taking care of weekend warriors and not professional athletes. Does the level of athletic play affect your choice in management?
The short answer is no. I use the high-demand athlete as a way to narrow the focus of the talk, because if you tried to include all the papers, you couldn't get through the talk. So what I'm basically saying is, if you look objectively at those meta-analysis in high-demand athletes, they have very high satisfaction and return to sport rates across the first two, AOT and osteochondral allograft. So I will tell you, and you can check the literature yourself, those results pass through to less demand, people with less demand, right? So what I'm saying is, if you can satisfy the high demand at a level that approaches 90%, that's a winner for me. And I'll take a 5.2-month recovery over a 12.8-month recovery any day. And when you kind of look at the expected recovery times following these procedures. So the answer is, I don't differentiate. I do it primarily based on lesion location and suitability for the types of whole tissue transfers that largely is mostly what I do.
Yeah, Riley, thank you. That was excellent. You started out your talk by saying that you used to do a lot of, proximal tibial osteotomies, distal femoral osteotomies. That last case of that large trochlear lesion and the patella lesion, it looks degenerative. I mean, maybe it started out at some point with an injury. And so my question is, in terms of changing the natural history after you do the grafting of that knee, do you still do osteotomies with these cases? And how often do you combine them?
So the ability to return to sports after osteotomy is unproven. And I will say just anecdotally, we've tried to look at it. I just don't think the numbers were suitable for publication. For me personally, I've never gotten anybody back to any high demand sports after an HTO. I have after a TTO, and I have after a DFO. That's just my sort of gestalt. That case in particular, we had a very distinct conversation about what this was for. And he had 7 to 8 months. So I knew if I added some sort of unloading osteotomy there, which would make perfect sense, right, in a 27-year-old or 26-year-old, would have been okay. So I listen. He's like, listen, I just need to make this money. You can give me a knee replacement at 30. I mean, that really was his mindset. But I just need to get back as quickly as possible. So we need to kind of figure out this osteotomy thing because I don't know quite where it fits. I will say that I call my rehab strategies permissive, not aggressive, meaning I trust patients. I'm like, if it doesn't hurt and you can walk on it, you can walk on it. I don't immobilize people for very long times. I don't use a lot of braces. And by and large, that has worked for me in terms of preserving muscle and allowing a quicker return. One interesting note about that case, I talk about that case in isolation. He had swelling. What I didn't mention is that he had in 2 years, he had 80 aspirations. Just swelling. So now he had the surgery. It's 6 months after surgery. He feels great, but he's got a chronic 40 cc effusion. So I'm worried about this effusit because I know it's got IL-1 and TNF-alpha in it, and I know he's just going to break down my grafts. So I get this idea. I'm like, maybe I'll put him on Humira. Right? Maybe I'll put him on Humira. I have to get rid of this effusion. So in the course of putting him on Humira, I got a rheumatologist. We started doing this workup. What do we find in the workup? He's got Lyme's disease. Lyme's disease. So I didn't make a big deal of it, but in that arthrotomy picture, she's got big, beefy red synovium. And I'm staring at this thing. I'm like, am I going to do a synovectomy? Now he's going to get stiff. I just had to say, all right, hopefully I'll just change the joint enough to fix this. So literally treated him with Doxy for a month, effusion went away. So I think he had Lyme's. Yeah. I think he had a predilection towards patellofemoral disease. No one picked up on it. He was never tested for it. And then he played. The biomechanics of being a basketball player led to joint degeneration. So we were able to change the joint a little bit by treating the Lyme's. And he's playing for Memphis this year. So it's a lot of lessons, It's never a dull moment.
Thank you. Another remote question. You mentioned early on literature focusing on CPM in early postoperative recovery. What is your current postoperative algorithm, and do you still use CPM?
I don't use a lot of CPM, but again, remember the predominant method I'm using is Osteo No Allografts. CPM, outside of the Stebbins-based literature, is not borne out. There are several papers out on early rehab and weight bearing after microfracture, which shows no difference between toe touch weight bearing for 6 weeks and weight bearing is tolerated. So it doesn't play a big role in my current practice. I'd rather the patients get up, move around, move their own knee, go get on a bike, go swim. That seems to be a better methodology for me, but it's not a big part of my practice. Oh, you guys have the remote thing down pretty good. I like it. It's good.
It works good.
Yeah.
I come from a research background, so my question, I don't know how relevant it is. For 30 years, various labs in US and Europe are growing tissue engineered cartilage. And they claim that their cartilage in the lab is pretty good compared to mechanically and otherwise. Attaching it to the bone surface was one of the problems. You showed some commercial product results. So what is the future of the tissue engineered cartilage, you think?
So there are a couple of things that I understand and a lot of things I don't. So one of the things I don't understand for example, is in the case of de novo, right, which is the minced juvenile cartilage. I don't understand how it adheres. I don't understand how the cells move. I don't understand, and they haven't looked at it. It would seem, again, I MRI everybody. I MRI every case for osteochondral allografts, get it at 6 months and 2 years. The cell-based therapies get 3 months, 1 year, 2 years. The only real comment I can make about that is that there seems to be, at least in the cell-based methodologies, some method by which there's some adherence between both the surrounding cartilage on the side and the subchondral plate. The problem with making, for example, say 3D cartilage in the lab is if it's not the patient's own tissue, I just don't understand how there's going to be a biomechanically sound bond between that tissue engineered cartilage and the subchondral bone. I don't know how to arbit that question, because again, that's not the way cartilage is made. Cartilage is made in utero, and it comes from that epiphyseal junction, and goes from the bottom up, not from the top down. So it's just an area that I don't think we're close to understanding with regards to the eventual binding. We're certainly much better, as you intimated, about making the reparate and having a reparate available. Nowhere near understanding how it fits in terms of eventually junctioning it, which is why, again, I just keep going back to it. That's why I like the whole tissue, because it's done and you're not waiting on any kind of phenomena like that to happen. Thanks. Thank you.
Any other questions?
Great.
Thank you so much for coming, Dr. Rao. Wonderful talk.
I'm going to ask everybody to just stay for 2 more minutes. Dr. Williams gets his plaque tomorrow night, but I wanted to introduce everybody to Joe Fiorito. Joe, come on up here. So I think a lot of us are not familiar with Joe, but he is a podiatrist at Harborview, and he's actually a great colleague for us. He takes on all sorts of difficult patients and cases at Harborview. He does it very quietly, never complains, never says no. And this happens to be the 5th year anniversary of hiring Joe. And so congratulations, and I hope I'm giving you another plaque at 10 years. This is your pin, and I think from now on we're going to have rules like in North Korea. Once you get this pin, you have to wear it every day. Okay. So thank you, Joe. I also wanted to thank Bobby Adams and his crew at Arthrex, who I've been told are also watching Grand Rounds today. This also is the 10th anniversary of the arthroscopy boot camp, and that's just been an incredible addition to our program, our residency, and thanks to Arthrex for hosting that for the last 10 years. So. All right, have a nice day. Hopefully we'll see everybody tomorrow night. Thank you. That was great.
That's great. Thanks, man.